Today's lecture is going to be on the vertebral column and the muscles associated with the abdominal region. Let me first start by giving you a little bit of an introduction on the vertebral column and its functions. The vertebral column, one of the functions, is to transmit the weight of the trunk to the lower limbs. So it is going to bear most of the weight from our head and our upper body, and it's going to transmit that to our lower body. The vertebral column surrounds and protects the spinal cord. So it is the bony encasement that is surrounding the spinal cord and protecting it. The vertebral column will support the weight of our head, and it also serves as an attachment site for muscles of the neck and back, as well as the ribs. And we'll talk about the muscles towards the end of the lecture. So here is a nice picture that shows you several views of the vertebral column. So you can see an anterior view, a lateral view, and the posterior view. And the vertebrae are categorized into three different regions. So the first 7 vertebrae are called the cervical vertebrae, and they are denoted C1 through C7. The second group of vertebrae are the thoracic vertebrae. There are 12 of them. They are going to articulate with our ribs and form a cage around the thoracic cavity and protect the organs that are deep within, such as our heart and our lungs. They are denoted T1 through T12. And then finally, we have lumbar vertebrae. There are 5 of them, and they are denoted L1 through L5. Also, towards the end of the lecture, we'll talk about the sacrum and the coccyx. So you can tell from the lateral view that the vertebral column takes the shape almost like an S. So the curves of the vertebral column occur over time as a child begins to, balance their head and then eventually begin to stand upright. So as you get older, you get this lumbar curvature down here. And then once we're able to balance our head, we begin to have this cervical curvature. So in a 4-legged organism, so those that walk on 4 legs, the spine kind of has this kind of curvature, okay? When we became bipedal organisms, when we began to walk on our 2 feet, our spine began to take on this curve. And this is to accommodate the weight of our head. And that's how we went from having a spine that looked like this to a spine that looked like that. All right, let's talk about some of the movements that the vertebral column can make and do, so that this will come back to this idea of movement when we're talking about the muscles of the abdominal region and the thoracic region. But this will give us a nice introduction on the types of movements that can occur in these regions. So in the cervical region, we have a lot of movement with our head, right? We have flexion, we have extension. So flexion would be bringing your chin towards your chest. Extension would be the opposite, bringing your head back. We have lateral flexion, that's moving your head, like your ear towards your shoulder, back and forth. And then we are able to rotate, okay? So those are the movements in the cervical region. The thoracic region, the vertebrae in the thoracic region have very little movement to them. The only movement associated with the thoracic vertebrae has to do with respiration, breathing. So as we breathe in and out, there is a little bit of movement that occurs within the thoracic vertebrae. The lumbar vertebrae have the same amount, same types of movement that our cervical vertebrae do. So you can get flexion, extension, you can get lateral flexion and rotation at the lumbar region. All right, before we start talking about the different types of vertebrae, I want to go over a typical structure of the vertebrae and kind of go over the components that you're going to see. I think it would be a really good idea to make a compare and contrast chart when I start talking about the features of cervical vertebrae, thoracic vertebrae, and lumbar vertebrae, so that you can identify them during a practical. So you want to be able to determine what features are important for each of those different types. So if you see them, you will know which one you are looking at. Before we get into the specifics, let's talk about just the basics. So the structure of a typical vertebrae. So all vertebrae share a common structure, okay? There is an anterior vertebral body here and a posterior vertebral arch here. All right, there are actually many components to the vertebral arch that I'll talk about in the next slide. The vertebral body is the weight-bearing component. So the cervical vertebrae have the smaller bodies, whereas the lumbar vertebrae, their bodies are quite large. The vertebral body and the arch form an enclosed hole, so you can see this hole right here. This is the vertebral foramen. The vertebral foramen is where the spinal cord is going to run through. This is what is going to protect the spinal cord from any kind of injury or damage. Now let's take a look at this vertebral arch and the components of the vertebral arch. All right, and these components, you will find these components in all of the vertebrae, okay? So I like this picture. I'm straying from your book for just a moment because I found this picture in Teach Me Anatomy and I really liked it because it highlighted the different regions of the vertebral arch to show you what the components are. I'm not as concerned with the definitions of all of these components as much as I want you to be able to identify each of these. So when you're in lab, it is important to be able to determine these features on all of the different vertebrae. So as we mentioned, this is the body. In green, so next to the body, are what's called the pedicles. Those are here. And actually, each of these regions formed a separate bone to begin with, and then they fused together to form the individual vertebrae. Off of the pedicles, you will find a transverse process. All right, this is going to be an attachment site for muscles, and the transverse process is actually going to look different on the cervical vertebrae compared to all the other vertebrae, and I'll highlight that once we get to the cervical vertebrae. But right now, I just want you to see the basic components. Next to the pedicles are what is highlighted in purple is the lamina. That is this region here. And then off of the lamina is the spinous process. The spinous process is this protrusion that you feel. So if you run your fingers along your spine, you will feel all of those bony protrusions sticking out. Those are the spinous processes of the vertebrae. Those are the basic components. There are going to be articulating processes, and I'm going to show you that more specifically when we're looking at actual images of bones. So each vertebrae is going to stack on top of the next one, and where those vertebrae come in contact with the vertebrae below it or above it, there are going to be articulating processes. This is where bone-to-bone contact is occurring, and I'll point those out as we get closer. So let me show you. So as I was saying, there are 7 cervical vertebrae. The cervical vertebrae are a little bit tricky compared to all the other vertebrae because there's a lot of differences among them. So I'm going to highlight them. But first I want to show you kind of what the cervical vertebrae, a typical one, looks like, and then I'll point out the differences. In all the other regions, they're mostly going to be the same, but the cervical vertebrae are a little bit tricky, and that's why a compare and contrast diagram will be very helpful. So the cervical vertebrae are the smallest of the vertebrae. They are delicate. They have small bodies compared to the other vertebrae. They do have large vertebral foramen though, because the spinal cord is particularly large in this region. Their spinous process, some of them have what is called a bifid tip. So that's what you're seeing right here. A bifid tip means that it splits like a V. It's not present in all cervical vertebrae, and I'm going to point this out. I have a really nice image of them all stacked on top of each other so you can see them all together. But some of them have this bifid tip. There is a transverse process right here, and what is unique about cervical vertebrae is that there is a transverse foramen in all cervical vertebrae. So this is in all cervical, all cervical vertebrae have a transverse foramen through the transverse process. And there are 2 things that pass through this hole, and I have another picture that shows this. The vertebral artery and the vertebral vein. All right, it's not so important right now that you know what passes through them, but that this foramen is present in all 7 of them. And this is going to be the distinguishing feature of cervical vertebrae. So if I had a particular vertebra out on the practical, if you saw a transverse foramen and I said, what type of vertebrae is this? You would know that it's a cervical vertebrae. I would never ask you to distinguish C3 from C4 per se, but it is important to be able to distinguish cervical vertebrae from thoracic vertebrae from lumbar vertebrae. And one other feature that I want to show you on this cartoon, and then I go on to show you actual real images of bone, so that when you're sitting in lab, you are able to identify these features, because lots of times these cartoons exaggerate the features a little bit. So as I was mentioning, since they stack on each other and they are going to articulate with the bone below it and above it, there's going to be a superior articular process on the top and an inferior articular process on the bottom. Okay, now that we mentioned what the typical cervical vertebrae looks like, I have to tell you that C1 and C2, cervical vertebrae 1 and 2, look nothing like the other cervical vertebrae. So I want to talk about C1 and C2, and then I'll go on to show you the rest of them. C1 and C2 actually have specific names. So C1 is named Atlas, and C2 is named axis. So the way they got these names, if you remember the Greek god in mythology, Atlas, he had his hand up, his arm up and his hand up, and he was holding the globe, the world, in his hand. So Atlas got its name because this bone is what is going to articulate with the skull. So if you remember the occipital condyles on the skull, the occipital condyles are going to articulate right here and here with the superior articular facet of the atlas. All right, the atlas is different because you can see it has no vertebral body and it has no spinous process. All right, it does have the transverse process. You can see them here and here, and it has the transverse foramen. Again, the vertebral artery and the vein are going to run through that foramen. C2 is called the axis. It also looks a little bit different from all other vertebrae because it has this bony protrusion here where the body would normally be, and that is called the odontoid process or the dens. You'll hear people call it the dens. C1 is going to sit on top of C2. I'm going to show you a little picture of that. And it's going to kind of swivel around the dens. And this is what allows us to rotate our head. There are a lot of the same features. So you're going to see the superior articulating process. There's going to be an inferior one on the other side. You see the vertebral foramen. This is where the spinal cord is going to run through. And now you begin to see a spinous process, and this one happens to be bifid. It has a V, it has a split in it. All right, this is what, I think this image is straight from your book, and this is showing you actual bone images so that you can see what it actually looks like compared to the cartoon. And you can use these pictures to identify the features when we are in lab and you are working with the bones. And what is nice is it is showing you a superior view and an inferior view so that you are able to see the superior articulating process and the inferior articulating process. Okay, same with the axis. You can see a superior view and an inferior view. This picture demonstrates how C1 sits on C2. So you can see that this movement of C1 kind of swivels around the dens. And this is what allows us to move our head in like saying no. The occipital condyles that articulate here, this is what allows our head to move in the yes position. So that is what is giving us this movement. All right, here is an actual image of a cervical vertebrae from your textbook. So it is highlighting some of the important features that I went over: the bifid process, the spinous process, the lamina. I'm not going to go through all of them because I really just went through all of them. The only one that I really didn't like is how it's showing you the vertebral arch, because I consider the vertebral arch everything except for the body. So please don't look at this and take what I said in, I think it was like the second or third slide when I was showing you the picture of the vertebral arch. The vertebral arch is everything, including the lamina, the pedicles, the transverse process, and the spinous process, everything but the body. All right, this is a nice image showing you all of the cervical vertebrae stacked on top of each other. So you can see the differences between the cervical vertebrae. You can see C1 and C2 all the way down to C7. So you can also note which cervical vertebrae have the bifid process and which do not. One more thing I want to point out, and I'm going to highlight this, is C7. Another term for C7 is the vertebra prominens, because if you feel the back of your neck, there is one bony protrusion that sticks out further than any other, and that is the spinous process. That is this region, the spinous process of C7. So it has a special name called the vertebra prominens. This image is showing you how the vertebral artery, and it should show the vertebral vein, is traveling through the transverse foramen of all cervical vertebrae. So this image is a little deceiving because it looks like it's not traveling through a transverse foramen of C7, but it is in fact. There is a little hole here, so I'm going to draw it here so it's not to be confused that all cervical vertebrae have a transverse foramen through the transverse process. All right, this is a typical thoracic vertebrae, and then I'll go on to show you real images so that when you're, again, looking at these bones in lab, you have more than a cartoon to look at. You can already see some changes that are happening with the thoracic vertebrae. So the vertebral body is bigger. The vertebral foramen is getting a little bit smaller. So here's the body. Here's the vertebral foramen. It's getting a little bit smaller because the spinal cord is a little bit smaller in this region. We still have pedicles. We still have a lamina. We still have a transverse process and a spinous process. We don't, however, have the transverse foramen. Okay, we lost that. There's no foramen here. There is one feature that is unique to thoracic vertebrae and found in no others. So there are 12 thoracic vertebrae, and there is a rib per vertebrae, so that the ribs are going to articulate with these bones. So you are going to see the presence of a transverse costal facet. This is where the rib is going to articulate. And there's actually two articulation sites for ribs. This isn't a really great picture, but I'm going to show you it on another slide. But this gives you the basic difference, like you can see the basic structure of the thoracic vertebrae here compared to the cervical vertebrae. So you can see the spinous process. We're not going to have any bifid processes, and we're not going to have any transverse foramina in thoracic vertebrae. So let me show you a better view of these transverse costal facet. So there's going to be a rib that attaches to all thoracic vertebrae. So this is like the distinguishing feature that should alert you to the fact that you are looking at a thoracic vertebrae. And then there's going to be other costal facets. There's actually a superior and an inferior costal facet, because there's going to be a rib sitting high in the superior location and then a rib sitting in the inferior location. This would be a good time to take a look at one of the full skeletons, the full body skeletons in the lab, so that you can see how the ribs articulate with the thoracic vertebrae. You almost have to look at it while you're looking at an actual skeleton so you can place them. So the rib is going to have two articulating surfaces. All right, one at the costal facet near the body, and then one is going to be off of the transverse process. So you will see a smoothened area on the transverse process. Here it is here. And that should tell you that you are looking at the thoracic vertebrae. All right, let's take a look at the lumbar vertebrae. So these vertebrae are the biggest vertebrae. They are the most robust, they are the thickest, and they are the strongest. And they have a huge body and a very small vertebral foramen. They still have a transverse process or processes. They have the pedicles, the lamina, and the spinous process. But we have lost the transverse foramina, of course, because that was only in the cervical vertebrae. We lost the costal facets because we are no longer attaching ribs here. And we have lost the bifid process. Here is an image from your book showing you the features of the lumbar vertebrae. So here's an actual image of bone. So when you are looking at it in lab, you can begin to make these features out. Again, these are the largest of the vertebrae. You can usually tell them apart from the other two based on the size of the vertebral body. All right, let's talk about a couple other things before we move on and talk about the sacrum. So I wanted to point out, I'm going to talk about the intervertebral discs, which are fibrocartilage that is in between each of the vertebrae to act as a shock absorber. We'll come back to that. But when you begin to stack the vertebrae on top of each other, there is a hole that is created as these vertebrae stack on top of each other. So the holes are called the intervertebral foramen. So that is what's being pointed out there. And how this is happening is that the spinous process of one vertebrae and the spinous process of the one below it are creating this vertebral foramen. And this is an area that is a passageway for spinal nerves. So if you look at some of the models in the lab of the vertebrae stacked on each other, you will oftentimes see, nerves are usually indicated by yellow. So you'll see the nerves that are passing through the intervertebral foramen. So it's important to understand how the intervertebral foramen were formed. And actually, there's a picture right here showing you the nerves that are passing through these vertebral foramen. All right, now let's talk a little bit about the intervertebral discs. So as I was mentioning, the intervertebral disc is fibrocartilage. So it's a cylinder that lies between the vertebrae, joining them together. And this allows for flexibility of the spine, and it also acts as a shock absorber. Now this slide is showing you the anatomy of the intervertebral disc. And there's basically two components, two regions to the intervertebral disc. There's what is called the nucleus pulposus, which is in the center, and the annulus fibrosus, which runs along the outside. So the nucleus pulposus is jelly-like. That's what's in the middle. And it is surrounded by a tough and collagenous material that is going to surround this nucleus pulposus and kind of enclose it. So you've probably heard of a herniated disc before. So what happens, and this typically happens in the lumbar region, in a herniated disc, the nucleus pulposus, so that's what you see in green, ruptures, and it kind of pushes and breaks through the annulus fibrosus. So again, the nucleus pulposus ruptures, and that is what then breaks through that outer ring. And when it does so, you can see how there were those nerves that were running through those intervertebral foramen. That is then going to apply pressure to that nerve, and that is going to cause a lot of pain. That is what a herniated disc is. And that happens, so you've probably always heard, if you're going to lift something heavy, to do it with your knees. So you're supposed to bend, bend down at the knees and then lift up. But when people don't do that, they just kind of bend over and they don't lift with their knees, that causes a lot of pressure on these discs. And it causes them to possibly be herniated. That is why it is so important to always lift with your knees, right? You know that saying, and that is how that is caused. So it's like when you bend over, that applies a lot of pressure to the lumbar region. All right, there are a few spinal disorders that are worth noting since we're talking about the vertebral column. And the first one I will talk about is something called kyphosis. So kyphosis is a thoracic curvature, all right? That's what is showing you here. So this is when the area of the thoracic region pushes out posteriorly. And this most often occurs in individuals as we age. So this could be a symptom of osteoporosis. So the bones of the vertebral column are getting weaker. So weakening of the bones. It can also be weakening of connective tissue and muscle. So elderly individuals sometimes have that curl or hunch over, and it can also make breathing more difficult. So that is what is referred to as kyphosis. There is also something called lordosis. This is when you have the lumbar curvature is excessive. So that's what this is saying here, but it got cut off. So the lumbar curvature is excessive. This most commonly occurs. It can occur in pregnancy with women, when there is an increase in the weight of the fetus, and it exaggerates the curvature of the spine and creates a temporary lordosis. And usually this can be fixed in time. As soon as you release that pressure and you don't have that weight anymore, it can generally fix itself. And then finally, scoliosis. This forms kind of an S shape of the spine. This is a lateral curvature, and this can happen in the thoracic or lumbar region or both. And this happens usually during a growth spurt or just before puberty. The causes of it are unknown. Usually most cases are mild, and most people kind of grow out of it as they age. There are a few important ligaments that help support the vertebral column. So I just want to go over these ligaments so that you are aware of them. So on this slide, I've highlighted two of them. One of them is called the anterior longitudinal ligament, and one of them is the posterior longitudinal ligament. And they are running the length of the entire spinal column, and they are around the body of each of the vertebrae. So they attach to the front and the back of the body of the vertebrae to help support it. It strengthens the intervertebral discs and helps to prevent herniation. And then on the other side of the vertebrae, so more toward the lamina region of the vertebrae here, there is a ligament called the ligamentum flavum. And this ligament is extending, so that's what's in blue here. It's extending from one vertebral lamina to the next inside the vertebral canal. So this is also going to support and help maintain the structure of the vertebral column. This ligamentum flavum is made up of elastic fibers. And then finally, there is the ligamentum nuchae. This is a ligament that spans from the occipital protuberance. Remember the occipital protuberance on the back of the head where the occipital bone is? And it is going to go down to the vertebra prominence, C7. And this is what is going to stabilize our head while we are running. So we don't have the bobblehead, like at a baseball game or those little figurines, how the head kind of bobbles around. This is going to help secure our head when we are running. Interestingly enough, I'm sure you've probably heard of this song. We all kind of sang it when we were younger. A paddywhack is that ligament. I think it's usually from a goat or some kind of small animal like that. They used to take this ligament and they used to put it over a fire and cook it, and they would give the paddywhack to the dog. So somehow it got the name paddywhack. So if you're ever wondering what this song meant, it has to do with the ligamentum nuchae. All right, let's move on to the anatomy of the sacrum. So the sacrum is a fusion of 5 individual vertebrae. And the 5th lumbar vertebrae, the last of the lumbar vertebrae, are going to articulate with the superior articular processes on each side. So I'm going to highlight, although I have them circled, the features that I want you to know. The sacral canal is where the end of the spinal cord is going to run through. And you will see sacral foramina on each side of the sacrum. So if you're looking at a posterior view, these would be called the posterior sacral foramina. And if you're looking at the anterior view, they would be the anterior sacral foramina. And those are regions or holes where spinal nerves are going to pass through. And I have another slide to show you that. And just a reminder, I always want you to know the features. I've put over here what is happening with these features, what the features are doing. But again, it's more important to understand and identify these features for the practical. I won't ask you what these features do unless I specifically tell you that I want you to know them. Along the middle, there's a ridge line right here. That is called the median sacral crest because it's a rise. It's kind of a protrusion coming off of the sacrum. There is, a sacral hiatus. That's this last kind of hole here is another region where nerves are going to pass through. Sorry, it's getting very loud. And then you can see the coccyx. The coccyx is also a fusion. It could be a fusion of anywhere from 3 to 5 bones. We're all a little bit different, so it just depends on your genetic makeup. This is the vestibular tailbone, what used to be the tailbone. There's no modern usage to the coccyx, except that there are a few muscles that attach to it. All right, I'm going to go ahead and still highlight these because these are the features that I want you to know. You'll also see these features in the lab manual so you can compare what features I want you to know from the lab manual to the lecture. And again, I've gone over what some of these features do, but I just want you to be able to identify them. All right, this is the view showing you how the spinal cord runs down the sacrum and kind of comes out of those foramina. That's all that it's just there to show you what that looks like. We'll study nerves more when we're in the nervous system. This is a book or a picture, probably very similar to the one that you have in your book, which is showing you what the actual bones look like instead of the cartoon version. Again, I only want you to know the features that I pointed out in the last slide, but I put this here so you can at least see what the bone really looks like. All right, let's move on to the ribs and the sternum. So this is also referred to as the bony thorax, which again includes the ribs and the sternum. The sternum is the bone to which your ribs articulate. And they articulate with the vertebrae on the posterior side, and then the ribs come around and articulate with the sternum. Not all of them are direct connections, so I'm going to go over the difference between true and false ribs. But you can see the ribs highlighted in blue. They are connected to the sternum, which is made up of 3 different regions. I'll also go over that. And they're connected through hyaline cartilage. That's what you're seeing in yellow. That is hyaline cartilage. Also called costal cartilage because it is what is joining the rib to the sternum. And then the sternum is highlighted in green. All right, so there are 3 regions to the sternum. They start off as separate bones and then they fuse together. So there is the manubrium, which is highlighted in green, the body, and then the xiphoid process. All right, and I want to take you through some of the features of the sternum that I want you to know. You can also see here's a lateral view. And this is where you're going to have articulation sites for the ribs. All right, let me put my highlighter on so I can highlight the features that I want you to know. So if you put your finger on the top of the manubrium, you can feel the jugular notch. All right, this is a little notch in the manubrium. Also on each side here is the clavicular notch. That's what's denoted here and here. All right, the clavicle is going to articulate here with the manubrium as well. All right, I totally misspoke. Let me erase this. The clavicle is going to come over here on each side. Okay, that's your collarbone. This is representing the very first rib articulating with the manubrium. So the clavicular notch is where the clavicle is going to sit, and here is the jugular notch. All right, so when you're looking at the sternum, be sure that you can identify the jugular notch from the clavicular notch. Let's highlight the manubrium here. There's also an angle between the manubrium and the body of the sternum called the sternal angle. So here's the body of the sternum and then the xiphoid process. Those are the features that I want you to be able to identify in lab that will cover the sternum. And as we were talking about today, although you're not going to hear this lecture for 2 more weeks, we were talking about doing CPR and how if you do not do CPR in the right location, you can actually break the xiphoid process. You're supposed to feel for the xiphoid process, move 2 fingers up from that, and then start compressions. All right, so let us talk about the difference between true ribs and false ribs. We also have floating ribs. So let's highlight these. So this is a good time to look at one of those skeletons that are hanging in the lab so that you can be sure to distinguish between true ribs, false ribs, and floating ribs. So let me go over and tell you what the difference is. So the first 7 ribs, and you can count them, are considered true ribs because they have direct connection to the sternum. So here's 1, 2, 3, 4, 5, 6, and 7. They all have hyaline cartilage that runs directly toward the sternum. The false ribs are kind of hijacking onto the hyaline cartilage of the 7th rib. So 8, 9, 10, 11, and 12 are considered false ribs. However, the last 2 ribs are also called floating ribs because they don't have hyaline cartilage and they don't attach to the sternum at all. Okay, so there's true ribs, false ribs. Again, the false ribs do not have a direct connection to the sternum. Most of them, all the way to number 10, are hijacking a ride up to the sternum through the rib number 7. So it's kind of jumping on the hyaline cartilage of rib number 7 to make it up to the sternum. And that's what constitutes true ribs from false ribs. And then floating ribs don't have any articulation at all. All right, so let's look at how, and I mentioned this when we were talking about the thoracic vertebrae. I talked about how the ribs were articulating with the vertebrae and that there were 2 regions that the rib could articulate with the vertebrae. One of those articulation sites was close to the body and one of them was on the transverse process. So that's really the most that I want you to know from this slide. It's also showing you the anatomy of the rib. Really, I just want you to know how it articulates with the vertebrae. I'm not going to ask you specifically what the anatomical features are of the rib, except for the articulation sites. Let me show you a better picture. This is actually real bone, so it's a real image from your textbook. Again, you can see the articulation site near the body, and you can see the articulation site near the transverse process. There is a tubercle on the ribs, and that is what is forming that articulation site. And then it really just is the head of the rib that is articulating here with the body. All right, I'm going to switch gears and talk about some of the muscles that we are going to go over for this particular section. So we're going to talk about a few of the neck muscles. There's not the cadavers don't really have the neck muscles dissected very well. So I think I'm just going to go over 2 of them. This is also a good time to always remember when we're talking about muscles that most of the information you need to know is in the lab activity. There's a nice chart that outlines all of the muscles, the origins, the insertions, and the actions, and then I highlight the ones that I want you to know. So I'm not going to spend too much time going over all of the muscles. I'm just going to give kind of a brief overview, and you are to use that guide as your resource for learning these. And we will be working with the cadavers and identifying the muscles that way. You've seen this slide before. This is to remind you about origins and insertions, that the origin is on the non-moving bone and the insertion site is on the moving bone. And then we'll talk about the actions. So I'm going to just go over, I think I'll go over 2 muscles that are located under the mandible and a few of the abdominal muscles. I haven't made my final determination on which origins and insertions I want you to know. So I'm going to go ahead and go over the origin, insertion, and actions of these muscles, but double check with the lab activity. I'll make my final judgment call based on what I highlight there. But I also think it gives you, when I go over the origins and insertion, although it can be tedious, it does give you a little bit of a clue as to what the actions are. So the first muscle I'm going to go over is called the digastric muscle. There are 2 of them, one on each side. They originate at the mandible and they insert into the hyoid bone. So here is that hyoid bone right here. They're inserting into the hyoid bone. So their action is to depress the mandible. It's going to pull down the mandible and elevate the hyoid bone. Okay, we use this muscle when we swallow and when we talk. The same is true for another muscle that sits deep to the digastric muscle. So it's deep, it's kind of one sheet of muscle. So that's what's depicted in blue. Again, here's your digastric right here. Di meaning 2, digastric. The mylohyoid sits underneath it. It also originates in the mandible. It also inserts into the hyoid, and it serves to elevate the hyoid and pull down the mandible, depress the mandible. It has a very similar action. And all of the other kind of neck muscles in the area are, again, not dissected very well. So instead of using plastic models, I'm kind of skipping over them. But I do want you to know this one muscle that runs down the neck. It's a very big muscle, and there's 2 heads to it. It is called the sternocleidomastoid. It has its name based on its origins and insertions. And it is readily identifiable on the cadavers. So it originates at the manubrium of the sternum. So here, okay, there's 2 of them. So it's going to originate on the sternum. It's going to insert into the mastoid process. Remember the mastoid process on the side of the skull. And this is going to allow us to have a lot of movement at our neck. So we're going to get flexion, lateral flexion, and then rotation of the neck. That is the sternocleidomastoid muscle. It's a very big muscle that runs down the side of your neck. We'll go over, at some point, we'll be looking at the cadaver in the prone position to be able to look at the back muscles. Some of these muscles that are in this lecture, you will see again because there are multiple actions. So some of the actions of these muscles have to do with movement of the neck, but there are other actions that we will talk about. So it also elevates the scapula. We haven't gone over the scapula yet. So you'll actually see this muscle again when we talk about the scapula, but I didn't want to delete it here because I wanted you to also realize that it is capable of movement at the neck as well. So the trapezius gets its name from its shape. It's shaped like a trapezoid. It's a very big muscle. It originates at the occipital bone. So here's the occipital bone. It inserts into the scapula. Here's the scapula. It's the shoulder blade and the clavicle. Okay, so the clavicle again is the collarbone. So, and the anterior part of the body, you would see the clavicle. And it has 2 roles. It has the ability to extend it allows us to extend at the neck, and it also elevates the scapula. So it pulls the scapula up. There are a couple important triangles. They're called the anterior triangles of the neck and the posterior triangles of the neck. These are important clinically because there are a lot of major vessels that run through or along the side of our necks, including the jugular vein and the carotid artery. There's also a lot of glands. So you'll often hear these triangles in the clinical setting. And now that you have some anatomical background, we can talk about what the borders are of these triangles. So this is a nice picture showing you the anterior triangle of the neck, and the borders are the sternocleidomastoids because it kind of runs on an angle, the midline of the neck, and then this line of the mandible, and that's what makes the triangle. It is important to know what is making up the triangles of the neck. So please make sure to understand the borders of these triangles. So if I ask them. So that's the anterior triangle of the neck. Let's talk about the posterior triangle of the neck. So the sternocleidomastoid muscle denotes both the anterior and the posterior borders. So again, it's the sternocleidomastoid, the clavicle here, and then the trapezius muscle, which we just went over here. So that is forming the posterior triangle of the neck. And here is a view of both of these triangles using an actual person, so you can see how these triangles would be important clinically because of these very important arteries and veins that run in this area. And they're supplying blood to our brain and draining the blood from our brain. All right, this picture is a typical picture that you would find in your textbook that shows all of the muscles. And I do like to show this because I know that I try to use images where just one muscle is highlighted, but it's always important to see those muscles in the context of all the other muscles. So we went over the digastric, we went over the mylohyoid. I took out a lot of other muscles, but we did go over the sternocleidomastoid. You will and should know where the clavicle is, and you can see where the hyoid bone is. All right, the last part of this lecture is to go over the muscles of the abdominal wall. These muscles are involved in movement of the lumbar vertebrae. There's a couple other features that I will go over when we are in lab and looking at the cadavers. All right, so I'm going to go over the rectus abdominis, the transverse abdominis, the external oblique, the internal oblique, and the latissimus dorsi, otherwise called the lats. But if I have asked you to identify this muscle on a practical, please don't write lats. You do need to write out latissimus dorsi. All right, this is just a review in case you are not familiar with the movements. When I'm talking about flexion and extension, this has to do with movements of the lumbar vertebrae. So this is showing you just what flexion looks like, what extension looks like. This is just FYI in case you don't know, so that if you're wondering what these actions really look like, you can see pictures of all of them, including flexion and rotation. All right, so I think I have these all on one slide. I do, that's great. There's a couple other things that I'm going to show you when we get to lab, but let's work this out right now. So the muscles of the abdominal wall are in layers. Okay, so the outermost muscle is the external oblique. All right, that's what you're seeing here. This is the external oblique here. And then right under the external oblique, so that is the outermost, the most superficial muscle, is the rectus abdominis. That's also what is referred to as the six-pack. That's all of these muscles here. That's the rectus abdominis. On the same plane as the rectus abdominis, so in the same level, is the internal abdominal oblique. And so you can kind of, and I'll show you these when we get into the cadaver room, but the internal abdominal oblique is named because the fibers are running, the muscle fibers are running at an oblique angle, okay? Same with the external abdominal oblique. So they're running at an oblique angle as well. And then finally, the deepest muscle is the transverse abdominis. And the transverse abdominis got its name because the fibers are running on the transverse plane. So this is probably best to see in person, but all of the fibers are running in different planes. So again, the outermost, the most superficial is the external oblique. All right, and then the next plane, you have the internal oblique and the rectus abdominis. And then deep to that, the deepest of all, is the transverse abdominis. Okay, and the transverse abdominis does not have the same actions as the other three muscles do. The only action that the transverse abdominis has is to compress the abdominal wall. All right, so the internal oblique, the external abdominal oblique, and the rectus all have other movements such as flexion, rotation, and trunk rotation and lateral flexion. But the transverse abdominis has a very limited action. It is just to compress the abdominal wall. A couple other features I'm going to talk about is this white line that you see here that runs, it's fibrous material that runs down the center, like as a mid-sagittal kind of cut. That is called the linea alba, which means white line. It is a tendinous material that separates the rectus abdominis muscles. You can sometimes see this white line, or the linea alba, on very pregnant females. So that line can sometimes be exaggerated when you're really far along in pregnancy. The other thing I will point out when we get to the lab is this white sheet right here. It is called the aponeurosis. Remember, we have been talking about various types of aponeurosis and where you can find it. There is an abdominal aponeurosis that is present. Sorry, this slide got really busy really fast. So those are the abdominal muscles that we're going to go over. Your job is to memorize their function or their actions, and I will point them out and so that you can identify them on the cadavers. And lastly is this very, very large muscle, the lats. Again, you're going to see this muscle when we're talking about, when I go into some future lessons and we start talking about the humerus, the arm bone here, upper arm bone, because this muscle has two different actions. So you can get some extension of the vertebral column, but you will also get, extension and adduction of the arms. I haven't really gone over adduction yet, but I will once we get to that point. But as of right now, it is to extend, it allows for extension of the vertebral column. It's a very big muscle. It's the most superficial one on the back. It originates at the thoracic and lumbar vertebrae, so all along here. Inserts, so this very big muscle inserts into the humerus, and again allows for extension of the vertebral column and extension and adduction of the arms. So that concludes this lecture of the vertebral column and the muscles that move the vertebral column.